Well, now that we're talking about infections in kidney, how can we not talk about HIV? The deadly HIV and kidney, and what are the different renal diseases it causes? How it causes, how do we treat them? And how does the treatment of HIV also influence the renal function? And what all referrals can you get as a treating nephrologist out of a HIV patient? So, first of all, the kidney diseases in HIV can be divided into the different compartment wise. It could be the glomerular disease, the tubular interstitial disease, or the tubular disease or the interstitial disease. Coming to the glomerular disease, the two most common glomerular diseases are HIV associated nephropathy, which is known as HIV or HIVAN, and HIV associated immune complex kidney disease, which is known as HIVIC. Please remember, HIV, that is HIV associated nephropathy, and HIV associated immune complex kidney disease, which is known as HIVIC. The others are the thrombotic microangiopathy. It could be even associated with MPGN, with or without cryoglobulinemia. There could be membranous nephropathy. There could be fibrillary immunotactoid glomerulopathies. There could be amyloid nephropathy, AA type, which is the secondary amyloidosis, or rarely it could be the minimal change disease. But of course, what you have to remember are two very important glomerular diseases, which are HIV and HIVIC. Very, very important. Coming to tubular diseases. Well, of course, very, very commonly, it can cause acute kidney injury. There could be by causing acute tubular necrosis, of course. There could be proximal tubular injury and cause Fanconi syndrome. A very important antiretroviral drug causes it. Very common pharmacology MCQ, very common nephrology MCQ. Others are, which are not that common, that could be diabetes insipidus. There could be chronic tubular injury, or even crystal nephropathy, which is of course again the side effect of antiretroviral drugs. Coming to interstitial diseases, you can have interstitial nephritis, which can be due to any damn drug that you could be using in an HIV patient. That could be caused by it, or even some viral diseases like BK virus, which could be an opportunistic viral infection in an immunocompromised patient like HIV. So, we have understood the diseases could be glomerular, tubular, interstitial. The two most important glomerular diseases are HIV and HIVIC. Very important tubular, it could be ATN, and other important is Fanconi syndrome. And interstitial nephritis, of course, it could be the AIN, caused by n number of drugs and infections and anything that could be causing an allergic immune response, and which could be causing the interstitial inflammation. Now, what are the risk factors that predisposes an HIV patient to certain glomerular diseases? Very, very important. The risk factors could be divided into certain host genetic susceptibility. It could be some socio-demographic factors. It could be some other comorbid conditions and their treatment related conditions. It could be HIV related factors, or it could be certain co-infections. Now, very, very important genetic susceptibility is the APOL G1 and G2 genetic variants. It is the APOL1, G1 and G2 genetic variants that definitely predisposes. Others that have a questionable role are the sickle cell variants and the ABCC2 and 4 genetic variants. But of course, not that important. If one thing has to be remembered from here, it is the APOL1, G1, G2 variants. Very, very important. Now, among the demographics, it is the age, it is the race, ethnicity. Now, I will tell you that certain races and ethnicities are specifically predisposed to certain diseases. For example, let me give you an example. Like Africans are very prone to HIV or HIV associated nephropathy, whereas the Asians and the Europeans, they are more predisposed to HIVIC. So it is the race factor also which has to be taken into account. Illicit drug use and socioeconomic status. Of course, the poorer people are more predisposed to HIV related diseases. Other comorbid conditions like diabetes, hypertension, cardiovascular disease, previous AKI, malignancy, and usage of traditional herbal medicines that causes a interstitial nephritis all the more. Now, other HIV related factors like HIV viremia, low CD4 count, and ART, whether ART will influence, whether initiation of ART will influence the onset and progression of kidney disease. Very, very important. And co-infections like Hep B, Hep C, TB, syphilis, all the other opportunistic infections that can happen in an HIV positive patient are also very important factors. But out of everything, if you have to take certain take home messages, it is the APOL1, G1, G2 variants, it is the age, ethnicity, it is the CD4 count, HIV viremia, and the ART initiation, which are very, very important factors. Now, what are the different diseases that can be happening in an HIV patient affecting the kidney, and how common are those diseases? Now, let me tell you, before the antiretroviral therapy era, it was the HIV which was the most common disease of the kidney in HIV positive patient. So this HIV, it was the most common disease in the pre-ART era. By pre-ART, I mean pre-antiretroviral therapy era. But ART is almost now available everywhere, that too free of cost in India by the government centers, and beautiful guidelines have been laid down by the NACO. So, HIV incidence has reduced drastically. But what has risen is the incidence of HIVIC. It is the HIV associated immune complex kidney disease, which is the HIVIC. And this is the most common kidney disease overall in HIV patients. Very, very important MCQ. Most common renal lesion in HIV patient is HIVIC and not HIV. If you follow older notes, older MCQ books, the answer given there is HIV. But that answer is wrong. What I am talking about is the latest guidelines, is the latest data that I am talking to you about. So please do not be mistaken by following the older MCQ books and the traditional old papers which are circulating in the market. Always trust the recent things which have been upgraded. And of course, diabetic nephropathy is again very common. In fact, it is more common than HIV in HIV patients. Other things are tenofovir nephrotoxicity. There could be FSGS, which is the non-HIV type, that is the NOS type. There could be global sclerosis. There could be ATN, other tubular interstitial disease, and other diseases. But again, the most common renal lesion in an HIV positive patient is HIVIC and not HIV. Please, please, please remember this. Now, this brings me to the very important topic about what is HIV and what is HIVIC. If we have to just understand both of them by a comparison, let us see how far we can manage. Now, in which population is HIV very common? I have told you HIV is more common in the African population, whereas HIVIC is seen to be more common among the Asians and Europeans. The important risk factors for HIV are: number 1, increase HIV viremia. It is the low CD4 count. It is the APOL1, G1, G2 variants, which are again very, very important. These are the risk factors of HIV. Coming to HIVIC, the important risk factors are: number 1, presence of diabetes, presence of hypertension. In fact, it is associated with lower viral RNA copies as opposed to higher viral RNA copies in HIV. And The very important difference being it is not associated with APOL1 genetic variants. There is no association of HIVIC with APOL1 genetic variants. It is the HIVAN which is associated in the Africans and in the with the APOL1 G1 G2 genetic variants. Now, what is the pathogenesis of HIVAN? Because it is associated with increased viral copies, there is direct invasion of the virus into the glomerular and tubular compartments. So it is basically a direct invasion of the HIV virus itself. But in HIVIC, as the name implies, it is not due to the direct invasion of the virus. It is due to the circulating immune complexes. It is due to the circulating immune complexes which causes the HIVIC, which is very, very important. After the pathogenesis, how does the pathology look like on a kidney biopsy in a HIVAN and in a HIVIC? So in a HIVAN, what is typical, most signature and pathognomonic finding is a collapsing FSGS. It is the collapsing glomerulopathy or the collapsing glomerulopathy, which is the signature finding of the HIV associated nephropathy. Along with it, what else do you find there? Well, you find tubuloreticular inclusions. You find tubuloreticular inclusions. You find dilated endosomal compartments. You find tubuloreticular inclusions, dilated endosomal compartments, and even the presence of pseudocrescents. This is the typical finding of HIVAN. Coming to HIVIC, you find immune complex mediated kidney disease. And what does it look like? It looks like post-infectious glomerulonephritis or PSGN, where you find a lobular enlarged glomeruli with diffuse proliferative glomerulonephritis. You can find that. You can find the pattern of a lupus-like picture. You can find an IgA nephropathy-like picture. You can find a mesangial-proliferative glomerulonephritis-like picture, or even a membranoproliferative glomerulonephritis-like picture. So you usually get a proliferative disease. It is usually a proliferative disease. Just like PSGN, IgA nephropathy, MPGN, or mesangial-proliferative glomerulonephritis, or even lupus-like. So what we have understood here is, here you get a typical collapsing glomerulopathy along with the tubular reticular inclusions and dilated endosomal compartments. And here you get the typical immune complex mediated glomerular diseases. Now, apart from this, very, very important thing to understand here is, how does this present to you? How does HIVAN present to you? The most pathognomonic feature of HIVAN, just like FSGS, is heavy proteinuria. There could be renal failure, and it is a very important cause of CKD with increased kidney size, just like diabetic nephropathy. And there can be hypertension and edema. In contrast to HIVAN, in HIVIC, you have microhematuria and subnephrotic proteinuria. So, the most predominant clinical feature is heavy proteinuria for HIVAN and microhematuria for HIVIC. And of course, there is increased kidney size despite renal failure in HIVAN, which is a very, very important MCQ. Which brings me to the revision of this question. What are the causes of CKD where you have CKD but increased kidney size? It could be due to diabetes mellitus, HIV. It could be due to amyloidosis. It could be due to even in rapidly progressive glomerulonephritis where there is renal failure but there is normal kidney size. This is very, very important. Coming to antiretroviral therapy. Now, ART will decrease the progression of HIVAN by 60%. But here, it does not lower the risk of end-stage renal disease. If you give ART, antiretroviral therapy, to a patient of HIVAN, he is less likely to progress to ESRD. But HIVIC has no influence on, it is not at all influenced by ART. This is very, very important. Coming to progression, HIVAN is a very bad disease. The progression is rapid in HIVAN, but it is slower in HIVIC. Now, patients reaching end stage renal disease after 2 years from diagnosis. So, if I say that today if I diagnose a patient to be HIVAN, I know after 2 years 70% patients will have reached ESRD, but only 30% patients of HIVIC reach ESRD after 2 years. So we have understood that HIVAN is a preventable disease, but it is very progressive, very rapidly progressive, and approximately 70% patients reach ESRD after 2 years from diagnosis if ART is not started at time. So antiretroviral therapy is a very, very important tool by which we can retard the progression of HIVAN. So I hope you have understood how HIVAN and HIVIC are different from each other as to starting from the ethnicity, the clinical features, the treatment, and the prognosis. How are they different? Now coming to the pathology of HIVAN. Now please see here, in HIVAN we have 3 different views of the kidneys here. In the methenamine silver strain, we have seen that how there is collapse of the glomerular tuft, and that space has been occupied by the podocyte hyperplasia. There has been increased podocyte hypertrophy and hyperplasia, and that has occupied the space which has been there where there is collapse. This is the collapse of the glomerular tuft, and this is the podocyte hypertrophy, which is appearing like a crescent to naked eye, but it is not. Here we see numerous tubular microcysts. I told you tubular microcysts with proteinaceous casts. And here what we can see is, we see tubuloreticular inclusions, intracytoplasmic tubuloreticular inclusions, which is known as the interferon footprint. And why does it happen? Due to interanastomosing tubular structures within the dilated cisterna of the ER. So it is due to the anastomosis of the tubular structures of the dilated endoplasmic reticulum, and it is known as the interferon footprint, which is present in the HIV associated nephropathy. So very important, you get the podocyte hyperplasia and the collapse, you get tubular microcyst and the interferon footprint, which is the intracytoplasmic tubular reticular inclusion. Coming to HIVIC, here what we can see is, here the patient presented to you with microhematuria and subnephrotic proteinuria, and here we can see mild mesangial expansion. And this very same patient, under the electron microscope, what can you see? You can see a very important MCQ. You can see the ball in cup appearance. What is ball in cup appearance? There is the mesangial deposits with varying numbers of subepithelial deposits resulting in the ball in cup appearance. This is the ball within the cup. So this is the ball in cup appearance due to mesangial and subepithelial deposits leading to ball in cup appearance. Please look here. This is the ball and this is the cup. I hope you can very well appreciate why is it known as ball in cup. So in HIVAN, you had the tubular reticular inclusions, the interferon footprint, and the podocyte hypertrophy pseudocrescent. In HIVIC, you have the typical ball in cup appearance due to the subepithelial and mesangial deposits of the immune complexes. Very, very important MCQ. Coming to the treatment. How do you treat these diseases? Of course, you will do blood pressure control for all. You will start antiretroviral therapy for all, irrespective of the CD4 count. You will give ART to each and everyone. In blood pressure controlling drugs, of course, you will prefer ACE inhibitors, ARB. Goes without saying. Now, what about immunosuppression? Whether you will give steroids or not, that is the question. Now, very, very important thing you have to understand is steroids are not for all. What are the indications of steroids? See, very importantly, you are immunosuppressing an already immunocompromised patient. It is an HIV positive patient. So do not add insult to injury. What is the indication of steroid in a HIV associated nephropathy? The answer is, first and foremost, you have to show that there is viral replication is suppressed, of course, by antiretroviral therapy. So there is less HIV RNA copies and the CD4 count is high. And of course, because the disease is too aggressive, so there is progressive decline in the renal function, or the proteinuria is increasing. So you have to, on one hand, show that the kidney is going worse day by day. And on the second hand, you must show that the body is capable enough of fighting the virus. Because the body is not capable enough, of course, you will not doom the patient by adding more insult to injury by adding steroids. So it is BP control, add ACE inhibitors, ARB if it's a proteinuric disease, add antiretroviral therapy, and steroid, of course, will be the last resort if you cannot do anything apart from that. Last but not the least, now, lot of MCQs are asked about the side effect of antiretroviral therapy. There are few drugs which cause very syndromic side effects in the kidney. What are they? Very important. Coming to protease inhibitors like indinavir. Now, indinavir causes crystalluria, nephrolithiasis, and papillary necrosis. It causes crystalluria, it causes nephrolithiasis, and papillary necrosis. That is the indinavir. Apart from that, even atazanavir causes crystalluria and stones. So protease inhibitors are very, very notorious to form crystals and stones. Coming to the transcriptase inhibitors like tenofovir, it does the classical proximal tubular damage leading to Fanconi's syndrome. Rarely it can cause damage to the distal tubule in the collecting duct and cause nephrogenic DI also. But we are most importantly associating it to Fanconi syndrome, that is the global PCD damage, and it will lead to glycosuria, amino aciduria, proteinuria, cystinuria, etc. So this is how you manage it. Now, how do we manage tenofovir induced Fanconi syndrome? They are to be monitored for signs of tubular dysfunction. That is, you have hypophosphatemia, low serum uric acid, and stuff like that. So, of course, you have to manage it conservatively. But if it is too distressful, for the patient, you might as well have to stop it and replace it with another drug. This is how you manage the toxicity of antiretroviral therapy. So protease inhibitors, crystalluria, nephrolithiasis, and tenofovir Fanconi syndrome. Very important MCQ. With this, we completed this topic of HIV and the kidney. Thank you very much.